Oh. Did everyone get that little notification?
Yes, I did.
What do we have to do?
You don't have to do anything, but we just wanted to let you know
It was there.
that, yeah, that we started recording.
Okay.
So that way for the volunteers that can't make it today, we're hoping we can send it out to them after.
Right.
I think I will. Okay.
Okay, Marissa,
Yes,
can you see my screen?
yes, we can see your screen.
Okay, I think. Now, do you just see what says audience window?
I believe so. We
Okay.
see
No.
supporting care systems through serious illness.
Okay, do you see, like, I just opened another page with my notes. Can you see that?
Yes,
Ah, damn it. Okay,
yeah,
well, that's okay. I might just do this. I don't know why, but for some reason I can't see my notes and it's okay. Because they're all on there.
Okay, let's give it a few more minutes,
Yeah.
people to join. Is everyone okay with connecting? You can hear us, you can see us.
Yes.
Yes. You can see you.
Yes.
Yes.
Hello, everybody, from Rebecca. You're in the
Hi,
Northwest
Rebecca.
region. I see the names now.
Hello.
Good morning, Marissa.
Good morning, thank you for joining. Almost good afternoon, I guess.
another minute, it's good afternoon.
1 hour.
You have a good turnout so far. It's great.
Yes.
Okay, now you should only see my audience window, Marissa. Sorry about that.
Yeah, I think you're good.
Okay, good. Still good? Just wondering.
Yes.
Yep.
Perfect. Thanks, guys. I would have done it though. So everyone that's already here, we're going to utilize the chat option if you're comfortable today. No one has to feel forced to do that. I'll go to the next slide, but I just want to note that Marissa said at the beginning of the recording, and it does say here on the front page, this is being recorded. Your responses won't necessarily be recorded, and what's typed in the chat won't be seen. So the other facilitator is going to help with, being as judicious as possible about, which questions they say, if it fits the vibe and pattern of what we're talking about. Anything else I will answer personally later. So if you have a personal question, you want to type it in there, or you want to message me personally, I will email you later if you give me your email. So I just wanted you to know that. So now as we're settling in today, please feel free, and we're not officially starting, I promise. I know people are going to want to grab a snack, use the restroom, take breaks as needed. So feel free to turn off your camera if you want. And put any reactions you have to what's going on in the chat, since most of us will be muted during the video or during the different videos that we're going to watch today. And yeah, we'll have a Q&A at the end. So Marissa, will you let me know when you feel like you want to start?
Okay, maybe give it one more minute, because I still see some people coming in.
Yeah.
Oh.
Hello to everyone joining. We're just going to give it one more minute and then get started.
Rebecca, did you get, this is Linda Whitworth. Can you hear me?
Yes.
Okay, thanks.
Oh, boy.
Hi there, Mark.
Huh.
While you're waiting for things to start, if you want, you can mute yourself. If you see the microphone button. And we'll get started here in a minute.
Okay. So is everyone good technology wise? You can hear us, you can see us. Do you have any questions before we get started?
No questions for me.
Okay, perfect. So I am very excited to introduce our guest trainer, Kelly DiTurno, to you. She's currently working as a bereavement coordinator for Hospice of the Western Reserve in Cleveland. Kelly holds a dual master's degree in clinical social work and public administration from Case Western Reserve University. And besides being a licensed social worker, I can also vouch that she is a terrific human being that I have had the pleasure of knowing since middle school. And I don't want to take up any more of her teaching time because she is a fantastic person to talk with. So I will just pass it over, and thank you, Kelly, so much for being here with us today, and thank you to all the volunteers for joining. We're really excited to bring this to you.
Hi, everyone. Okay, I just realized my camera wasn't on. So for those of you who have your cameras on, cool. I love seeing your faces. If you want it off, today we're going to find out is all about comfort. So again, as I had in that first settling in slide, people are going to keep coming in because they have real lives. So that's okay. So, you know, if you need to eat, go ahead and eat. If you need to turn off your camera, if you need to answer a phone call, please just make sure you're muted before you do so. Thank you for your time today. So yeah, as Marissa said, I work currently in Cleveland for Hospice of the Western Reserve, a hospice, one of the largest hospice providers in Northeast Ohio. And I bet you're wondering how my work relates to yours. So as a bereavement coordinator, I follow care teams and families of a patient through the entirety of their disease process once they come onto hospice services. So not all of the patients, the cancer patients that you are working with right now will end up on hospice. But the care team model is really important to everything that we're going to talk about today, because we're talking about systems of care. That was the title of our presentation. And so we're going to keep making connections between what I do and what you guys do today. But the main one that I really wanted to focus on is, is that the disease process is discussed for a very long time after either someone is in remission, is cured, or they pass away. So, and we do like to say died in my work. So I will use that word a lot, and we can process that later if you guys are uncomfortable with it, but that is a word I'm going to use a lot. But so the disease process is discussed for a very long time by the family members. I can vouch, I meet with them after someone dies, and the names and faces and contributions of the volunteers they work with come up all the time in the work I do. And that is why it is so important for me to be able to be here and have contact with you guys to teach you guys a little bit about what care systems feel like from the inside for the patient and their family members. And then to talk a little bit about protecting yourselves. So on our time and the last thing I just want to say before we get started is all of the patients that you are working with, whether or not they die, will experience loss. And we are going to talk about that today. We're going to talk about lots of different kinds of losses. And we're going to talk about how you can give even when someone's lost without trying to make it better. So we're going to define some terms around care or client systems. We're going to talk about disease processes. We're going to speak to, or not speak to, we're going to hear from two survivors themselves. And we're going to process. And then we're going to have an opportunity at the end where it says repair there, where I have an offering for you to do what we call a self-keeping exercise. It's a loving kindness meditation. And you guys will be able to turn off your cameras and participate to the level you're comfortable. But I think it will be helpful after some of the topics we talk about today. So let's get into it. A couple of important definitions. So I've used the term care system a couple of times. All you need to know when I say care system, client system, patient system is that interdependence is instrumental in healing and addressing serious illness. So behavior is influenced by a variety of factors, right? We know that our socioeconomic status, our location, how close a neighbor we like lives to us. We might have neighbors close to us, but if we don't get along with them, we might not benefit from the care of their friendship. So when you're working with clients and families, you may hear terminology, care system, client system, used not to refer to the hospital you're in, but to the group of people who are impacted by the care that's being given. So important to remember, you are both part of a care system and you have impact on the care system. So we'll keep talking about that. Some other helpful definitions that we have today.
Sorry, I'm going to interrupt you for a second because what we're seeing right now is just blank, and I don't know if it's supposed to be blank.
Oh, right now you're seeing, how long have you been seeing blank?
All the time.
Oh no, I'm sorry.
Well, we saw it when you first brought it up, but it went away.
I don't know why that is. Let me just figure it out and I will. I'm so sorry.
Oh, we see something now.
Okay, you see it now?
Yeah.
Okay, sorry about that. Okay, so we got into definitions. You can see my screen now.
Mm-hmm.
Thank you, Marissa. So yeah, so this was the last slide. So a care system or client system is what I said before, that you are both part of now and being impacted by. Okay, so I'm going to use those terms a lot. There are three other terms I'm going to use. These all can be used clinically and they can all be used informally. And so we're going to use them kind of informally because of the work that we're doing, but all of this matters to the care system. Okay, so self-determination, the ability of a patient to identify, name, and respond to their circumstances through active decision-making. It may also be referred to as agency. So when we hear from two cancer survivors later in our presentation, we are going to learn a little bit about what self-determination sounds like and learn a little bit more about how we can keep ourselves from getting in the way of other people's self-determination when they're folks living with cancer. Next is self-keeping. This is also colloquially or popularly known as self-care. And that's active work, boundary setting, and stimulus control that we're doing all the time to regulate and co-regulate our systems as needed. We use self-keeping in the work that I do because it's about keeping ourselves on track and not necessarily the more co-opted version of self-care, which is really more about buying things. So then the last one we're going to talk about is self-disclosure, and we'll talk later, a lot later in the presentation about self-disclosure, but these are personal details about ourselves that we might offer to a patient in order to increase connection and intimacy with them. In order to do this well, it requires humility and intentionality because the clients are full people who come with lots of worries, traumas, and histories that we need to be either aware of or if we're not aware, careful about. So we'll talk about that as we go on. So one of the reasons that we do this is not a speech, or this is not a talk or a discussion about vicarious trauma, secondhand trauma, burnout, or compassion fatigue, but these are things that all of us in the client system are always, oh, can you not see my screen again? You can see it, okay. So these are things that we are always vulnerable to. All of us have the capacity to burn out. Our patients also have the capacity to burn out. A lot of our patients who are going through treatment are actually caring for other patients right now. So other family members of theirs. So this is an important handout. I've got a really great matrix for it that I will send to Marissa, and she can send out if she so chooses. This is from the
I
center.
have a training that I forgot about, but do you know how one training?
Hey, if you're just joining and you want to mute, go ahead. Okay. But yeah, so I'll send that off to Marissa so you guys can stay aware of what you need while you're doing the volunteering. So how we counteract the losses and the pain during the process of living with cancer when we're a support person is by increasing the relational wealth of the patient. So how do we do that? We do that with the presence of attuned caregivers and extended family members, teachers, mentors, faith leaders, and other community members. So you are part of that. Volunteers are part of that. Connectedness with others is so important to our ability to heal. So later, we're going to talk to two physicians who don't always know the right answer, and mere exposure to your presence is what you have to offer. And I want you to remember that. So if you guys would feel comfortable typing in the chat, without knowing what this term means, I want you to look at that word, non-human losses. And when we're talking about patients and the people surrounding them, we're talking about losses during the cancer disease process. What are some non-human losses that might refer to? Can anyone type in the chat what they think? Thank you for the person who said mute yourself. Awesome, Kathleen. So the ability to do things you used to be able to do, absolutely. A lot of this time, it's not just losing the full ability, it's losing partial capacity to do something. And then we experience what we call role strain. We're not exactly sure who we are. So when we're bringing new people into our lives, when we're going through a disease process, it's pretty confusing because we don't feel like our whole selves. Is there anything else anyone has an example of? More recently, home loss. Oh my gosh, Rick, thank you so much for bringing that up. Yes, there are so many systemic factors that play into your ability to access care, to heal, and then to advocate for yourself within the system if you do get access to care. So home loss is a huge piece of it. We do have instances of people, receiving hospice services in homes that are not their own, or in long stay hotel rooms and things like that, because they might not have somewhere to be and they still need treatment. Other losses might be educational attainment. So the opportunity for educational attainment, maybe the ability to have your own biological children, the loss of a pet. Yes. Oh, and a volunteer after my own heart, being part of the sandwich generation. As a gerontologist, I just love that you said that. Do you want to type in the chat what being part of a sandwich generation is? I don't want to take that away from anyone because I will. I'll give you a second. That's okay. So being a sandwich generation, the people in my father's generation, are now one of the only generations who have had both their adult children come home and have responsibility for caring for a parent or family member. So multi-generation, and they are smack dab in the middle of that generation, just trying to figure out how to take care of themselves, how to prioritize their needs, and how to be a good caregiver. So thanks, that was a big one. And then physical appearance changes. Yes, absolutely. And we're gonna talk about that. We're gonna talk about hair, we're gonna talk about bodies, things like that. Okay, and so who better to hear about these things from? Thank you guys for that. And you can keep putting them in there. But who better to hear about these things from? Oops. Then Diane Thomas and Jacqueline Smith, who are two of our survivors that we're going to hear from today. We're going to start with Diane Thomas. And some things that I want you guys to be thinking about while we're watching this TED Talk from a survivor, a cancer survivor, is to think about what the patient is navigating. So here are some examples of what Diane talks about navigating. And I want us to add to this list and also discuss it afterwards. So navigating Medicaid, Medicare, VA benefit systems, educating themselves, their family and caregivers on emerging treatment options. So that means doing a ton of reading, doing a ton of suspending belief, maintaining their own social emotional well-being, right? So your own mental health when you're sick also is conflated with the mental health of others. How do you separate yourself and think of yourself? And how do we support them as volunteers to do that? And then symptom identification and management. That's happening all the time. There's, cancer patients have to be so aware at all times of their disease process and be able to report. So what we can support them with is reflecting back to them how they look, how they're doing, how they seem, without being insensitive or judgmental in the process, but purely helping them in the way they want to be helped. And then doing spiritual exploration, life review, and then doing tons of processing and forgiveness with their family members. And that's a huge part of what I do. I work with anticipatory grief in addition to grief after the death. And part of anticipatory grief is just talking through what we're afraid of, what we're afraid we won't get to be able to say. And you as a volunteer who's socially available to that person or who is available to them socially in the context of the care system can have some really great informal conversations with them. So we are going to start with Ms. Thomas, and hopefully I'm going to, oh yeah, I can do this. Okay. Hold on, I will mute. Maybe I won't.
What will they say next? On the power of dreams.
Earth, do you say? Earth, do you say? Today, I'd like to have a conversation about cancer, so that if you find yourself in that kind of a scenario, you are more prepared to be the best friend possible to that person. I'm a 2-year survivor, and I've had the privilege to speak with a number of other warriors about our shared experience. And today, I'd like to pull back the curtain a little bit and share some insights from this side. Some mine, some from that group, so that if that awful C word does come up, you are more prepared. And chances are, if you haven't had that conversation, it's probably coming soon because the numbers are scary high. I recently read it's 1 in 8 for my particular flavor. And I want to start with 2 things for those conversations that nobody warns you about cancer, and I wish they had me. And the first thing is that cancer isn't this simple concept that you can put an easy label on and be done. We talk about heart disease or diabetes or a root canal, like there's this tiny little box that it fits into, but not so with cancer. There are a couple of types of lung cancer, a couple of types of colon cancer, multiple types of breast cancer based on a number of different factors, which leads to the second thing about cancer. Diagnosis isn't just an event, it's also a process. One really tough visit to the doctor could be followed by what might be weeks until you get a really firm sense of what's going on. It may not be until the other side of surgery. Stage and treatment plan can change. There are multiple doctors involved and test after test after test, which means that it's virtually impossible to get your footing. That rug gets yanked out from under you and the ground does not quit shifting. And while you wait, you fret about your family and you wonder about whether or not you're going to die. And darn it, life does not have a pause button. There's still work and bills and my daughter and the dog with allergies and the house cleaning and the laundry don't stop. And the crazy doesn't stop when you finally make it to treatment either. Maybe it's chemo, maybe radiation, maybe both. Maybe it's pills, which means hazmat disposal at home. The list of side effects is long and pretty scary, and maybe they change over time. Maybe it just makes you tired, like the folding a basket of laundry makes you feel like you run a marathon kind of tired. Or maybe the meds to keep you from being sick make it so you can't sleep no matter how tired you are. Or change the way your favorite foods taste. Now they taste like mildew or aluminum foil, and that's not awesome. I've talked to some people who never wanted to be a burden or a bother to their children. And what about my husband, who's now carrying the whole load? How did just 12 weeks of treatment somehow feel like a geological age? Do I still get to talk about things I want to do 5 years from now or not? And into the midst of this, now you, my sibling, my friend, my colleague, maybe you heard about my news and you want to check in. Maybe we were talking and it just came up. You're concerned, you want to do something if you can. For better or worse though, oftentimes when we hear that word cancer, the first place we go to is to death. Or maybe that worst image we have of chemo. And we're challenged by living in a society that doesn't do well talking about bad stuff, like life insurance or depression, or sometimes just admitting we're having a tough time. Even in communities of faith, we struggle. We go to that inspirational quote, that sports analogy, that favorite scripture. We try and take the edge off somehow, look for that silver lining. But when we're too quick at that, we lose that current challenge and the pain and the discomfort in this process. So what can you say or do to be an effective friend? Because remember, the ground is still shifting for me. I can't get my footing. We're in Florida, that hurricane I'm trying to stand in. What can you say or do? Let me start with 3 fit topics. It's probably okay that you can just skip over. And the first one, interestingly enough, is stage. And I get that you're trying to understand how serious this thing is or what might happen. But stage 1 doesn't mean it's easy. And stage 4 doesn't necessarily mean I'm about to die. Stage is really for the doctor's record keeping and is not a good barometer for how I'm handling it. So since it's not real helpful, let's skip that one. The second thing you can probably skip over is my hair. And I get that you're probably trying to encourage me because we live in an image-obsessed society after all. Maybe I am afraid to lose my hair. Or maybe that clump that came out in my hand is the worst thing I've experienced and I don't want to talk about it. Or maybe in the middle of that crazy hurricane, the last thing I'm worried about is my hair. I don't have to shave my legs either, so it's not all bad. But whether it's irrelevant or difficult, that emphasis on image can just feel a little weird, so skip that one too. The third topic you can probably leave off the table for now would be alternative treatments or my diet. And yes, you might have read about this really neat herb or this amazing superfood, or maybe you're worried if I don't change my diet, I won't beat this thing and you want me to live, and I appreciate that. But until such time as chocolate really does cure all ills, remember that my emotional and mental capacity is pretty taxed right now, and I may not have a whole lot left to defend my own research or my choices. So if instead you make a comment like, there's a ton of stuff online right now in there that keeps me out of that defensive place and gives me options to talk with you to the level that I feel up to it. The conversation gets harder though, and it's more important for you to be that really great friend when talk of the process comes up. Because much like me, you probably want this thing out and gone before it can go any further. But even if you're frustrated by the process that insurance can sometimes create, or maybe you even wonder if my doctors know what on earth they're doing because they're sending me for one more test, Now isn't the time to debate that. These doctors are generally speaking wonderful people who hate cancer as much as you and I do. They may have family touched by it. They're probably as frustrated by insurance. They're looking for the least impactful option with the best possible outcome, and I'm asking them every question I possibly can. So if you say something like, I've heard this process can be confusing. Again, it keeps me out of that defensive place, and there's a camaraderie in it. Like you get it at some level and you're walking along with me. And most of the time, that's all I need.
Okay, so Marissa, I don't know how we want to do this, but I do want to get some reactions. People have been comfortable typing in the chat. Are you okay with them unmuting themselves if they want to specifically talk and not type?
Yeah, we're okay with them being able to unmute themselves in
Great.
case it's easier at talking and chatting.
Great. Okay, guys. So in the just trying to get rid of this. Is your view of this slide obstructed by people's faces? Or no?
No.
No, okay, good. Sorry. Okay, so what initial reactions does anyone have? If you want to unmute yourself, you can. Marissa, if you can see and anyone's raising their hands.
Do you want to maybe take it off screen share for a second so we can see if people are trying to talk? I think
Yes,
someone just put it in the chat too.
Yes, okay, thank you. Oh, great. Okay. Susan said, I think the fear of the unknown is a factor and always having to ponder our own mortality. Yes, absolutely. So much of what Diane talked about can make us nervous about not knowing answers, or we can use it as an opportunity to let her teach us. And that's the next video we're going to watch is going to talk a little bit about that. Anyone else have any reactions?
I thought it was really helpful that she gave a few ways to kind of bring up the conversations that you want to bring up, but not have her, be in a defensive mode, that you're there with her, not like asking questions to pry or to interview, but you're trying just to support.
Yes, camaraderie is the most important thing. So actually, I practiced this presentation for some of my colleagues earlier this week. What I wanted to hear from them is, how do I make this sound more informal so that the language I'm giving you guys can be helpful to you? And so I'm with you. I've heard this process is hard. Does what we refer to as putting us next to the client or meeting them where they're at. So instead of the problem being the disease, being something that's sitting between you and you offering help to help them deal with it, it's you two sitting next to each other and figuring out together, how are we going to get through this day that you're sitting with me right now? So
I think Anne might have something to say.
Oh yeah, go ahead.
Anne, are you raising your hand?
Yes.
Go ahead.
So I am a 10-time cancer survivor, as recently as having half my colon removed in April. And I connect very well with the patients because as they are most of them know because I was out, and they seem to be, it seems to really help the bond of them when they get their infusion, when they're trying to find a vein, and many of them, as all of you have noted, when your body is really been attacked as often, you can't find the vein very often, and the nurses are 2 and 3 times poking at them. So I find being very honest, whether I had cancer and I did raise 3 children with cancer. It really matters to them that I really feel their situation and just can comfort them just by being there. I think it's really important. If any of you have anybody in your family or have had cancer yourself, don't be ashamed to talk about it, because the patients feel a lot. You're not just a volunteer, you're more an empathetic bonding person with them. I found that I developed a lot of, as you know, Marissa, you've been there, a lot of close relationships with the patients. Just welcoming in, they know, oh God, that person knows what I'm going to be doing right now. And it's mattered. Thank you for letting me talk.
Oh my gosh, Anne, thank you so much. And this is exactly, Marissa and I talked before this presentation got put together about the fact that you are the experts. I have a position where I provide space for people to tell me about what it's like, and lived experience, we can't divorce it from, we can't separate it from the work that we're doing. And that's what makes it different for me as a clinician. My lived experience does inform what I do, and we'll talk to other clinicians who it does. But there are times in our professions where we have to put a wall up, and volunteers occupy this beautiful place where they can use their lived experience in a safe way. So thank you so much for sharing. Anne, Mark, you say, when I have an infusion monthly, I drink a lot of water the day or two before the morning of the infusion. Go ahead.
Yep.
Nurses appreciate this very much as it helps them. So you're thinking about how you impact them too, right?
Yep.
I love that. I'm
yes,
so
I do. I try to be. I try to be encourage people and be positive, because I think it's really helped me a lot. And I'm also, I think it helped other people when they do it too.
Yeah. Mark, thank you so much.
You're welcome.
Thanks, Jane. Go ahead.
I'm sorry. Can I
Go
say?
ahead,
Okay. And I absolutely ditto everything you said, because I too am, I don't know if you want to call it a cancer survivor, but I'm dealing with 2 cancers and I do volunteer. And I have to tell you, when I tell the patients who come in, who look worried and scared, I always tell them, look, I've been in your seat. I know what you're going through.
Yep.
If you want me to hold your hand while they're trying to find a vein, I'll be more than happy to. And it really, I think, is an amazing, it helps them a lot.
Yes, ma'am.
I just, I feel that maybe in this particular case, because I'm a volunteer in a cancer center, having cancer myself has been a big plus.
Yep. We are warriors.
You are warriors.
Yeah. I didn't put the camera on because honestly, ladies, I look terrible. So I'm going to video.
I think you're adorable.
Oh, thank you.
Well, you sound great, so I don't think it matters. I also have Nancy in the chat echoing what you guys are talking about. And this is, our presentations are so specific to who shows up, but I'm also a 4-year survivor. Nancy, do you want to say what you said, or do you want me to read it for you?
Yeah, I can say something.
Yeah.
Yeah, as I say, I'm a 4-year survivor. I was treated over at the Florida Cancer Associate Center by a wonderful doctor. And I'll just add, one of the things that I love about him, and still to this day, when I go in for checks, is that he always listens to me. And if there's something I do not want, because I do my research, so if there's a treatment or if there's a medication that I do not want to take, you can be sure I have an alternative. And so I'll usually start out by saying, okay, I don't want this, and here is why. Here's what I would rather take, and here is why. And almost always he'll say, I don't have a problem with that. Let's do it. So I'm sure there are times where he might disagree.
Yeah.
But I really appreciate that. Yeah, what I had said was that when I was initially trained for doing this, I was told, and I shared with the young woman I was kind of shadowing, that I had cancer. And her reaction was one of almost horror. You can never say that to a patient, And I said, well, I probably wouldn't do that. I'm not silly. I'm not a fool. you know, I'm not just going to stand up and make an announcement. But having been there and volunteering now for, I don't know how long. COVID has completely messed up my head. So, you know, whether it's I guess it was 3 years, because I started pretty much after my treatments, and maybe 4 years. There have certainly been times where I have felt that it would be very appropriate to share with somebody. I know a lot of these patients as we get to know them. Some of these people I've known for, you know, a number of years.
Right.
And no, I'm not going to go up to every single person and say, well, I had cancer, so I know what you're feeling. No, of course not. But there have been times where I felt that it might be appropriate to say, you know, exactly what you're advising, but coming from a place of, yes, I do understand how confusing this time can be. And because I really do know.
Yeah.
And yeah, I don't necessarily agree that that's the proper way always to approach this. And yet that's always been in the back of my head, and I'm always afraid to share it with anybody.
Yeah.
So I'd be interested in your opinions on that.
I'm so excited that I'll send you your check later. I'm so happy that you brought this up. This is actually one of the slides way later in the presentation, but we're going to it because this is, I think, again, everything is impacted by who shows up to a meeting like this. So what is self-disclosure? Whether you've gone through a cancer disease process or another disease process, most of us have gone through some, or we've cared for a family member who have, we always feel an urge to increase our ethos, or how trustworthy are we to the patient by disclosing something about it, even if it's just, I know what you're going through, right? And so Diane has already given us a couple of good ways to do that, which is to say, hey, I remember this being really hard. What's it like for you? That does two things. It acknowledges that you've gone through this, but it doesn't center you. And you might not want to be centered. One thing that Diane says later in the presentation, she says, most people don't want to talk about their health regularly anyway. So if you don't want to talk about yours, but you still want them to know, you know, what I recommend is thinking about self-disclosure before you go into your volunteer experience. So self-disclosure is information we give to a person, like we talked about earlier, to increase intimacy. It builds rapport, it builds trust. It reduces perceived risk of harm. If I say something I'm going through and you're just like, there's a scene from Scrubs where JD says to the janitor, you ever have a day where you're just in everyone's way? And the janitor looks at him and says, no. And he's so forlorn because it's so hard when we open ourselves up to someone and they don't understand what we're going through. Oops, I've moved past. Okay, so avoiding self-disclosure is almost impossible when we're working with people who are going through what they're going through and we want to be there for them. So with intentionality, we can do it well. So I want to give you some tips on creating a self-disclosure shortlist for yourself. This is a go-to list of things you're comfortable disclosing about your own life. I'm very comfortable disclosing I am an adult who lives with kidney disease, and I also live with dyslexia. I'm comfortable with my patients knowing that, but what I'm not comfortable with is I say, it's something that impacts my job a lot. So I don't like to talk about it a lot when I'm at work, but I'm okay with you knowing I have it and I see your struggles in the world. That isn't always bad. As a social worker, I have a different position than maybe some physicians who would not disclose at all. Your job as a volunteer is to figure out with each client, using all of the instincts that we just talked about before, what do you feel comfortable sharing about your story and what don't you? And then make a short list and read over it before you go in the next time. Certain ways you want to say things, you want to word them, could be helpful. Does anyone have an example of something they don't mind their patient knowing about their disease process, and then maybe something that you wouldn't want them to know? Any examples? Or that you wouldn't want to worry them with?
Anne,
oh, go ahead.
Anne, unmute yourself.
Oh, sorry, I can't see.
He's muted.
And did you want to say something? Because you're muted right now. Do you want to unmute?
Okay, okay. So I too was trained, my first training was told that, you know, you don't reveal anything about, you never talk about yourself and reveal anything about yourself. So for quite a while I didn't. And then it was interesting because I had raised 3 children with cancer. I knew a lot about the infusions and what bags were hanging and everything. And several of the patients started, this is before they knew I had cancer and I was gone for 2 months because of my late surgery. They said, they asked me, how do you know so much about that? And that's when I knew it was the right time to be able to share. And not with every patient, but as I became friendly with each one. And it made them feel so much better. You're there to get poison in your veins, been there, done that. And here's a person that not only survived it, but is here to be with me so that I can go through this. And this is my future, that I can come back and help others. And Marissa will tell, I cannot wait for Mondays on my day. I love what I do. And I thank you profusely, all of you volunteers. I hope you get the same rush that I do and love it as much as I do. But it really mattered to these people who are feeling so lousy to see that there's a cure. There's a way to come back, and even on my bad days, I'm there. So I just want to let you know that it really matters to be honest.
Marissa, I don't want to put you on the spot, but as someone who's seen the volunteers in action, do you think they generally do a good job of balancing that warning about what self-disclosure could do with their natural instincts as survivors and caregivers themselves?
I think so, yes. I think typically the ones who have gone through it themselves do a pretty good job of feeling out the room, feeling out who could use that information right now, or just kind of that helpful hand, just knowing that someone else in there that's potentially on the other side of it, they're helping them, is, just right next to them. It's nice.
Yeah, awesome. Thank you so much. So that what you're talking about is the difference between the art. I know that my screen probably went away, but the difference.
No.
Oh, it's good. Okay. The art and the science of working with cancer patients. And I right now am working in the science, but you guys get to work in the art. So while you do have volunteer expectations, you also have instincts, and you also have the ability to talk to anyone who trained you about specific instances. You could also reach out to me. I love processing these things. So when we're not sure if what we're disclosing could be traumatic to the other person, that's what this list is for. It's to really look at it and think, when I was going through this, if someone disclosed this much information to me, how would I have reacted? And so that's what I want cancer survivors and caregiving survivors to think about. And I do think that that is a good rule of thumb. There are the thing that's important is if it's mentionable, it's manageable. And if we make disclosures and it's successful, that's great. And if it's not, the fixes are more important than the ruptures. So we can go back and say, once you're past this, or I hope that you get past this and get to make the choices that I'm making today. And I'm not always perfect at being a survivor, like I wasn't always perfect at being a client or a patient.
So you can't wait, Kelly.
Yes.
You're not sharing right now.
Oh,
so
right.
If you are on screen. And Susan, did you want to say something? Are you raising your hand?
Yes, I have volunteered. It's over 5 years. And it seems like the most important thing is being able to hear and listen to the patients. I'll give them information about my own, recovery and experiences, but they have to believe that their experience is foremost. And when they see us, okay, they see the gray hair now, and I'll show them a picture of what I used to look like with the long, dark, almost black hair or whatever. And if they can realize that there's an end to their treatment, and it's a good end and it's positive, I think that's what's important. Giving them hope, not false hope, but
Right.
just realistic hope. And once again, I think it's just being able to listen to them before we interject anything about ourselves is like really important.
Amazing. Thank you so much. I really do appreciate it, because that's exactly what this idea of self-disclosure is about. We would have come to it a little bit later, but I do think that this is actually a good example of how things really play out with family members. Hold on, I'm going to try and share again. Okay. But not this slide. Okay. So so much of what happened today with someone disclosing pretty early on that they had cancer, that can happen. And it's bursting out of us. We don't always get opportunities. So I think that, yes, your point is well taken. We do need to balance listening with engaging with the client and telling them what we've been through. What I want to offer to you is that is a complex process that we learn how to do right after practicing, trying it out, and failing a little bit with our clients and allowing them to say, this is too much for me right now. Someone who I think does this beautifully, I am so glad that Marissa sent me this. So Dr. Rahl's stories, 5 ways to live before you die. We're not going to get into all 5 ways that he lists, but I really wanted you guys to contemplate some of the thoughts here, and we can talk about how he uses self-disclosure at the beginning of this video in a good way. So we're going to move into that right now.
I do believe that my passion for life definitely have been impacted by my relationship with death.
Yes, I mean, I did contemplate death.
We always talk about life and death, and actually death, like something that is not close to us.
Dying is easy, it's living that scares me to death.
As children, we grow up thinking that death is a bad thing. I think the way we embrace death should change.
The reason why I decided to specialize in oncology, I was exposed to cancer before getting exposed to medicine. My father was diagnosed with cancer. When I understood that healing is more than treating a disease, that includes the mind and the soul, that's when I realized that I want to do more for my patients.
In the case of Dr. Story, he's got a great bedside manner and great humanity to add to his skill set, and that is so powerful.
He's great. He's always been great. He comes into the chemotherapy room, says hello, sits with me. He makes you feel very comfortable. He just made you.
One moment, friends. Sorry.
My father was diagnosed with cancer.
Great humanity to add to his skill set, and that is so powerful.
He's great. He's always been great. He comes into the chemotherapy room, says hello, sits with me. He makes you feel very comfortable. He just made you realize, like, life is beautiful.
The most difficult part of my profession is to communicate my message effectively in a compassionate way and supportive way to every individual that is completely different.
My first reaction that I had when I found out I had cancer was, okay, I have to live for my kids, so I have to try to push really hard and do what I have to do to get through this. When you get a cancer diagnosis, you can't
Like you try really hard. Some days are really hard to not be upset and worried.
I think when you get a stage 4 metastatic cancer diagnosis, you immediately think you're going to die, or that your days are numbered.
I was prepared for that. In fact, I remember lying in bed the night before they were doing the biopsy, and I said to myself, it's 50-50, Greg. It's either yes or no. And I was able to sleep that night because I had been contemplating my mortality.
One of the most impactful things about oncology is that allow me to share space with humans that are going through life and death experiences. And it's there, being part of that journey, that makes
Friends, this is one of those ruptures that happens. I'm so sorry about the video. Can you guys hear me and can you still see the screen? Yes, thank you. Okay. Lynn, thank you so much for reacting. Yes, your very own Dr. Story. He does say that it makes it worth it. I would like for us, because of time, and I'm so sorry for the technical difficulty, but to jump into talking about what does it feel like to see a physician talk about and disclose that he was touched by cancer and how it informs his practice. Does it make you feel safer that you too can figure out how to do that well? Does it intimidate you?
I think it makes him more human.
Agreed, Linda. Yes. Can you say more?
Well, I mean, knowing that he went through it and he can offer ways to you as a patient that might be scary to you, but he can make it seem less scary for you, you know, more comfortable in the conversations and everything. And he's had experience of knowing, okay, this is treated this way because he's a physician, but it might affect you that way, you know.
Yeah. So if we take Dr. Story, what Dr. Story has shared, and the experiences that we've shared so far, and we think about the things that Diane said, considering all of the different things she's talking about, she talked about stage, she talked about losing hair, she talked about hunger and fullness, she talked about still having to do chores at home. How can we take what Diane said and the ease with which Dr. Story shares the narrative of why he became a doctor? How can we let them inform each other? What does Dr. Story do? What could he do for a patient like Diane to make her feel less stressed when he sees her exhibiting more symptoms, let's say? Do we have to always talk about how people look? Maybe not necessarily.
Can I say something? I don't know how to raise my hand.
Oh, that's okay. Yeah, I'm sorry.
Yeah. Well, I was thinking about what you just asked. I think it's not always necessary, even for the doctor, to necessarily say, I've gone through this. I know what it's like. I think it is helpful very, very often. But I think of giving a feeling or a sense of, we're in this together. We're going to get through this together. I know these additional symptoms are hard, and I'm so sorry for that. But we're going to work through it. We're going to figure this out. I think a team. We're a team in this.
Yes.
And you're not in this alone, you know, and I know for me, I think that's helpful, you know, not just for a doctor to say, I want to try this medicine. I want us to try this. I think this might help.
Yeah.
I think just knowing that, no, this is something we're walking through together. I'm not going to leave you on your own in this.
Yes, and to to marry the two things that you've just said, was that Rue who was speaking?
That was Nancy. It's me.
Nancy, okay, thank you. So to marry the two things you were just talking about, it is quite literally by the act of using the information we have and synthesizing it within ourselves. We're a system in it within ourselves. We create the experience of what we're communicating to another person. So you can always be informed. Dr. Story might not intimate to every single one of his patients. The volunteers who are here today who have lived experience with cancer might not intimate to all of their patients, the way Anne and Nancy said so well earlier, every piece of their journey. But disclosure is something that we know we can't avoid all the time. So doing it safely is important. So I really appreciate you guys talking through this exercise. It sounds like you have more to talk about with it. And so anytime you can get together with another volunteer and talk about how you've disclosed in the past and really think about what does that mean to you and how did it help, you can go forward with it. So we've gotten pretty far into this. It is almost 1 o'clock. So I've got a couple of different offers for the end. I do have a loving kindness exercise I would love to offer to everyone here, to just sort of debrief after, or not debrief, to decompress after we've talked about these things. There's a lot more to say. There's a lot more content in this presentation. I will still have the presentation. How are we doing on time, Marissa? I know that it's almost 1. So if we go over 5 minutes with an exercise, is that okay?
Yeah, totally. I think if anyone has to drop off, of course, you are welcome to leave at 1, but I mean, I think we're okay if we go over like 5-10 minutes.
Yeah, and then I'm gonna stay on for like a couple minutes after. We'll do a mini Q&A, and we probably, any questions you have, probably incorporate any of the other slides. So for now, what I'd like to ask you guys to do, first of all, we've had a lot of tumultuous changes, partially because of my technology today. Thank you so much for your patience. Let me ask you guys to turn off your screens if you'd like. And this is an offer to you as a recalibration exercise that you can do anytime during the day. But I want you to remember that we do this exercise with patients too. And a lot of times the person they're thinking of when they do this exercise is you or other volunteers they've worked with. So we are going to start. So I recommend listening to my voice during this meditation with your eyes closed or softened and fixated on one object. I also have the script for this that I can provide to Marissa to send to any of the volunteers afterwards. So for this practice, it's really especially important, all the volunteers today, to think about your bodies, no one else's body. For this practice, it's really important that we're in a comfortable position. So either laying down or seated. Your camera's off. I don't know what you're doing. To help us focus and gain some initial stability, let's bring our attention and awareness to the breath in our belly. So we don't want to control the breath. We're not judging it. This is not a breathing exercise. I'd like everyone to inhale and only notice the sensations of your breath. Exhale without a lot of pressure. Notice yourself breathing evenly. Today, we're going to talk about receiving loving kindness. We're going to shift into a practice of joy by bringing the mind somewhere we really believe, to bringing to mind someone we really believe has our best interests at heart. So someone who's extended kindness and support to us. This could be someone we know or someone from the past, a friend or a family member. So everyone who's here, I want you to choose one person and bring them into your mind's eye as though they were seated right in front of you, smiling at you. Imagine them truly wishing for you to be happy and fulfilled, for you to have a life that's flourishing. Imagine them beaming towards you with their smile in their eyes. And you, with your next breaths, inhale and draw in the intention of that goodness. In meditation and visualization practices, we have an opportunity to generate positive emotional states right here and now. Now, letting go of this image or letting it soften, notice that in the body, there's emotional residue. So feelings of warmth and goodness still stay afterwards. So with that feeling of support that we have when we think of that person, we can now extend and boost. We can now extend this boost of joy to others. So bring to mind someone in your life who could really use an extra boost right now. And again, bring them to mind vividly like you did the last person. Without too many stories or thought or ideas, just call upon the experience of wishing this person the best. This could be someone who you don't have a lot of good thoughts towards. Try to picture their face and remember that to someone, this person is everything. This person is the most beautiful, the most talented, the funniest, the surprise package that their parents wished for. To someone, they're everything. Twice more, inhale, drawing in this intention towards them. Then exhale, sending it out. Release the image of this person too. We are always releasing people and calling them back into our lives. Just notice the sensations in your own body associated with thinking of someone who's shown love towards you, and the sensations in your body thinking of wishing another person well. Let's bring this practice to a close with 3 long inhales. I wish you peace as you go back to your day. We had a lot of really hard disclosures today that were helpful, and I hope you listen to that feeling. And when you call upon the image or the sound of the people who disclosed their journey today, I hope that you can feel that loving kindness towards them and bring that into the volunteering you're doing. Okay, so I want to tell you guys, if you have questions, please either type them. I'm going to stay on for a minute, and I will make sure that Marissa has a potable version of this presentation and the handouts so they can send it to everyone. Thank you guys so much. Does anyone have any comments, questions? Oh, I see. Thank you. Dawn, Rebecca, Nancy, Marissa, anything that's come up for you while we've been doing this?
If you want to stop sharing your screen, then we can see people better.
Oh, yes. Thank you.
This is Nancy.
Hi, Nancy.
Hi. First, I just want to say good job. You know, the tendency, at least my tendency after doing this for, like I said, 3, 4, 5 years, whatever it is, I was almost reluctant to get on. You know, it was kind of a sense of, I know what I'm doing at this point. I was a psych major. I had cancer. I know what to say, what not to say. But you were very good. You presented everything really well. And it's amazing how much we can always learn. So I thank you for that. As for myself, I'm really glad. I feel like I've been given permission to share if I need to. I'm not saying I'm going to go in and make an announcement, but I feel like I have a certain permission that if I feel the need arises, which I feel it has in the past, and I've just squelched it. And I really wanted to say, I'm so sorry. You know, I was not in exactly the same place that you are, of course, but I know something of my own pain that I went through. And so I'm so sorry. And I just want to add that I think sometimes patients do pick up on these things. I know there was one gentleman who I've seen for years, And he's very sweet, always very kind to me, and gives me this giant hello, and always thanks me. And one day, it was quite a while ago, he made a comment. I don't remember where it came from or why, but he said something about, oh, you don't know, you just don't know. And he must have seen something in my face. And he just said, oh, you do know, you do. And I just smiled at him. I didn't really say, I didn't confirm or not confirm, but he just shook his head and said, oh, now it makes sense. Now I know why you're the way you are. And I think it does help some people to know. You don't want everybody to just be volunteering because it's a volunteer position after you're retired and you have nothing better to do. Someone else had said, I don't recall who, that, you know, it was a privilege. I recently said to somebody, I feel like I've been given a new calling, you know, and I feel responsibility, and I do feel honored that I'm, you know, able to go in to see these people every week. You know, I call them my patients. I was worried during the storm, how are my patients doing? You know, so.
And so long as you always balance the self-care piece, or the self-keeping piece that we talked about. So managing your expectations about how much you can control about a person's disease, right?
Yes.
Managing your expectations and tempering your expectations about how much their disease is going to end up looking like yours, is how you manage, or is how you make sure that you're not showing up and giving them more than they can handle. But we can't give you an absolute black and white idea of what that looks like. So Nancy, thank you so much for all of your.
Thank you.
Okay. Is there anyone else who has a comment? Can you quickly say something for the volunteers who aren't survivors? Yes. Hi. Thank you so much, Marissa. Marissa, oh, and I read it out loud, sorry. So for anyone who's a survivor who's young, or not who's young, I do have a slide about that. So Jacqueline is one of the survivors who's under 30, who I had created, or we were going to listen to her story. We just ran out of time. The most important thing for you guys to remember is that this happens to students. And it happens to students sometimes while they're working with or caring for other people with cancer. So remembering that they may be taking on a lot. So the volunteers you're working with and the cancer patients you're working with may be taking on a ton of emotional labor for those people that they're taking care of. And they may also be volunteering too. They may still be in school. So I want us to remember that if you don't have a story yet, you will have one soon. So today we talked a little bit about, because survivors had showed up, about how to make a survivor comfortable enough to feel like they deserve to be in that space with the expertise that they developed being a survivor. But that doesn't mean that you don't bring your own stories too. You've had your own losses. And much like Nancy just said, when someone can see in your eyes, you understand, sometimes that's enough of a self-disclosure, if that makes sense. So any other questions, concerns, yelps for help? Lynn, thank you so much for being here. I didn't get to talk to you individually, but
I think Terry might have been raising her hand.
Oh, go ahead, Terry.
Hi. Well, a couple things. I just wanted to say I liked Nancy's comment about listening, and I don't think anything can possibly replace human compassion and kindness and empathy. And I mean, that's basically what I tried to do. This week was a particularly hard week for me. I'm gonna get emotional. It was just literally almost every person that came in felt horrible. And normally it's just like, I'm great. You know, the first thing I ask them is, how are you feeling? And they're like, I feel really good. And I'm like, great, you know, we're going to do this. This week was horrible. And I had, it's been bothering me all week. one of my favorite patients tell me that she just didn't think she could do it anymore. And hearing that broke my heart, but also I didn't know what to say. You know, I sat with her, I held her hand, and I don't know what to say to that. I have not had cancer myself. I've had many, too many to count, friends pass away from cancer. My best friend, and I did not know what to say. You know, to say you want to stop treatment is, and I it's not that I don't understand that, because I do. I totally understand that she said that, but she's been fighting cancer for 7 years, she told me. But I did not know what to say besides listen and, you know, be there for her.
Yeah. So Dr. Kevin Dieter, who is one of the TED Talks that was prepared for today and will be in the slideshow, and I'd really love for you to watch, talks about, for him as a physician, Dr. Story had the framing of what he presented was much more, it was lighter and more positive. We can still have positive experiences or fulfilling experiences that don't feel that exact same way and have really more to do with accepting and being humble about the fact that we cannot control that our patient may die and they may choose not to keep intervening.
Right.
And so what he talked about there is that when you don't agree, the most important thing is to remember that it's not your disease process. And that's why we talked about that self-disclosure list before, is every time you either disclose or you acknowledge to yourself, when we can't help but do that while we're working with patients, that this is impacting you and triggering you, you bring that residue home. So every time you come home, doing some sort of journaling, writing it out, processing and thinking through and talking to someone who does not have cancer about it is important to manage your feelings so that when you go back into that situation, you can be what we call disinterested. So that's not disinvested, you're still invested, but you're not interested either way about what they choose to do because it's in their interests, not in yours. So that's
it's not that I don't agree with her.
Oh yeah.
I just, you know, my heart was just
yes,
didn't know how to react or what to say, or, you know.
And maybe what you needed, maybe you're doing now what I just said, which is talking to other people. And some people in this room have had cancer and some haven't, but all have chosen to be here knowing this topic was going to be on the table.
Right.
So you're not necessarily putting anyone in danger, and it's a safe space for you to process through how hard that was to hear her say it without making her deal with it. And that is how to be a good volunteer. So thank you for that information, or for that example. Okay. Well, I am actually going to, I think, just give you guys the opportunity to, if there's anything you want to say as we're logging off or as we're leaving, any comments, not questions, go ahead, but we'll wrap up. And Marissa, is there any information you want me to know or anything you want me to have going forward about why you did this or what you think you guys will get out of it?
We really just wanted to offer something to the volunteers that we haven't in a long time, especially with COVID and everything, is that we had, you know, a guest trainer come on, and you're an expert in this much more than we are. So we just wanted to provide that for our volunteers. Rebecca or Dawn could say more if you want to.
Yeah.
Honestly, thank you so much for doing this for us. As Marissa said, like, we've been racking our brains on what to do for the volunteers and how we can provide a really great training opportunity for them. And we asked them in a survey, and this is what they came, they spoke, and they said, we want to learn about supporting cancer patients and speaking and communicating with cancer patients. So we're like, okay, we're going to come up with something great. And Marissa suggested you, and I thought it was great. So thank you so much for taking time and doing this for us. I know you didn't have to do that, but we're very, very grateful. So thank you.
Thank you. I'm so grateful to you guys. I appreciate it. And
Kelly, everything they said.
Thank you, Dawn.
Mhm.
And if you guys invite me back, what we'll
Yes.
know next time is we probably need to have one topic at a time. Because you guys have so much to say, and I love that. So thank you. And then Nicole, thank you. I see your comment. All right. Well, I am going to hop off so that I can get to my next meeting, but thank you guys so much. I will, you'll get some literature from me later. Okay.
Awesome.
Yes, we will be sending
Thank you,
resources that
everyone.
Yes.
providing.
Okay. Bye.
Thank you.
Thank you so much.